So I'd like to thank Rajni first for inviting me into the session, and I'd like to thank Dr. Jalali for setting the pace. It's been an excellent talk, ma'am. I think we learned a lot from that as well. Despite us doing a little bit of electrophysiology, I think the amount of experience that exuded from your talk is something that we should all be inspired by. Thank you very much. So, pediatric electrophysiology is definitely a little different from adult electrophysiology. We're trying to maintain as many of the adult standards as possible. There are the ICEF standards. ICEF standards, I think the latest ICEF standards is in 2015. So the 2015 standards is not very much different from the older standards, but a lot of those rules sometimes get broken when you're doing pediatric electrophysiology, and just an idea of how we do this pediatric electrophysiology is big Ganzfeld simulators that were there with the older ones have now been replaced with these handheld Ganzfeld simulators with a Fresnel lens in front, which makes it easier for you to do children awake. So nowadays we're doing younger and younger children, and we're definitely trying to do them awake as much as possible and try and rely less on things like anesthesia and other things, because as madam said, these things definitely affect ERGs in a way, maybe in a more subtle way, not as much as to, for example, in Leber's congenital amaurosis, when you get something flat, it's predominantly flat. If there is a photoreceptor problem, as ma'am said, it's really quite a stark difference from what is normal in that age. So the types of electrodes we use in pediatrics is really not very different from what we use in adults as well. We try and stick to the same sorts of electrodes. Something that I use more for general anesthesias and sedations is the jet electrode, and the reason why I do that is because it has 4 spikes that come out of the contact lenses, which keeps the eyelid open, which means I don't have to really put in an eyelid speculum when they're sedated or when they're under general anesthesia, to just place that in front of the cornea at that point. There was one girl who sometimes even, some of these girls who even tolerate the electrodes as much as possible when they're awake as well. So some of those children we can even insert jet electrodes when they're awake. But as you can see, when I tried to insert the second electrode, by the time she went haywire and started crying, at which point we definitely had to induce her under anesthesia and do the test under anesthesia. Nowadays I don't do as much under anesthesia as I used to under anesthesia, because I've started using sedation more than anesthesia in those children who it's absolutely required in. But older children definitely tolerate all sorts of electrodes. There's even a boy who tolerated the burinalin electrode. It's hard for me to tolerate the burinalin electrode very easily in my eye, so hats off to this boy. He's definitely a little braver than I am. We also started to get our normals in children without anesthesia. The way we got this was with skin electrodes, and as you can see, with skin electrodes even applied just to the front of the eyelid, you do get a response. Now this is just 2 responses, and we didn't want to go more than this. This is a comparison to an adult response with the electrode on the cornea, so the difference between that and this is going to be huge, but this at least tells you that there is a response. The answer whether there is a response or is no response is very important in diseases like Leber's congenital amaurosis, especially when they're presenting in that age. And doing it with a skin electrode is something that we learned how to do thanks to Dr. Tony Robson. So that is the type of waveform that you'd get for a scotopic bright flash. So as bright a flash as your machine can give, just with an electrode on the eyelid can give you some response. And the flicker is less degraded by electrical noise. So when you try and use a flicker instead of a photopic flash, you sometimes see a response which you don't see in a photopic flash. How do I know this infant is normal? This infant is my son. He was 10 months old when I did his ERG, and at least I'm keeping my fingers crossed that so far he's normal and not showed any signs of dystrophies or any such things, at least right now. So the reasons why we do this on children is many. One of them is for night blindness, and when they come to you with night blindness, there are many reasons that a child can have night blindness. Vitamin A deficiency, CSMB, rod cone dystrophy, and enhanced Escon syndromes are some of those things that you can get. This is a typical example of a child with congenital stationary night blindness, where if you can see the A wave is much larger than the B wave, and this is how high the B wave should have been. But this is just to explain what these 6 plots are. This is when we do it with a dim flash. This is when we do it with a standard flash. This is when we do this with a bright flash, which is either the 10 or the 30 candela per meter squared responses. This is the oscillatory potential, and this is the photopic, and this is the flicker response. So as you can see over here that we even with a disease that affects predominantly the rod system of photoreceptors, the cone also gets degraded a little bit in CSNB because of the way things are wired, and the flash is obviously, single flash is obviously a little more abnormal than flicker in these situations. Of course, as madam said, you really can't say this is CSNB unless you have done the fundus examinations, and we go even a step further to do the OCTs over there. We also get the electrodes, we also get fundus autofluorescence done to make sure that it's nothing else but the diagnosis that we're putting in with an ERG at that point. So this was a case where I was sitting in the room and I thought this might be incomplete CSNB, but I was naive at that time. So I was wondering whether this is a CSNB or a rod cone dystrophy. But things looked a little different, and as madam said, in the flicker over here, you can very easily say that these things are delayed over here, and that should have signaled a certain abnormality to me. When you look at this, you don't see that it's like a typical CSNB. I mean, you would expect a normal fundus, and that's predominantly what we got. But then we knew it's a rod cone dystrophy because of the autofluorescence that we did after. And then we started to notice that the rods were probably just earlier affected than the cones. And this was the progression since we got this in a child. This is how it looked in a child without any of the fundus findings of a real rod cone dystrophy. A typical rod cone dystrophy, of course, in much later in life is like this, with most of the waves flat. And this is a typical retinitis pigmentosa with those types of pigments in the side. And OCT will show you that there's only some amount of photoreceptor left in the center over there. Now, was this a rod cone dystrophy or not? This is also something that threw me off a little bit. The waves don't look so abnormal. Definitely the rods look more abnormal than the cones do. But you are seeing waveforms over here. What was striking is that it's really delayed, and the delay is something that should bring about the possibility of an enhanced S-cone syndrome over there. Of course, Dr. Rajni has the distinct advantage of having seeing the fundus before she sends the patients to me. So she already knows all this information before it comes to me. I have to figure it out when I'm in the lab. Those pigments over there, that I'm not showing you the typical one over here, but those nummular type pigments are typical of enhanced S-cone syndrome. And when you do the autofluorescence, you see the pigments even in those autofluorescent areas as hypofluorescent areas. But really the clincher over there is the non-ISF standard test, which is the disease for the S-cone, the test for the S-cone itself. When a normal S-cone A wave should be like this, in an enhanced S-cone syndrome, the A wave is really much larger, which means that most of the response over there is coming only from the S-cones over there. This is the way we test for S-cones. We bleach all the L and M cones with an orange stimulus, background, and we put in a blue stimulus, which is which stimulates only the S-cones to give you that kind of a waveform over there. A younger child with an enhanced S-cone syndrome gives you less degraded waveforms. Definitely the rods would be abnormal at that point, but the other waveforms are actually, the cone waveforms are actually matching up in the single flash over here. But again, in this child we could not get much of an autofluorescence over here. But again, the clincher over here is the S-cone response itself, which is much larger than the other responses. Yes. Yes, that's right. Yes, we can. We can definitely suspect it, but the clincher is you don't need the S-cone testing to do it, but it becomes really obvious to us once you have that done. And we don't, as I said, most of these cases are diagnosed by Rajni herself instead of sending it to me. But whenever we see something like this, we always do the S-cone over there in the drawing. Early onset nystagmus is one of the other reasons we do this in pediatrics. the reasons for early onset nystagmus are listed out here. This is what Madam would have called maybe an rod monochromacy, but this is a actually I think this will be more a cone dystrophy. A rod monochromacy would have this being flat. So this is definitely a cone dystrophy, and something that we're looking at a reduced response but not an absent response in the cones over here. This again had a normal fundus examination. Leber's congenital amaurosis is one of those diseases where you have all of the waveforms flat, and sometimes by definition you need to have done this before you label them as Leber's congenital amaurosis sometimes, especially when the fundus looks as normal as this. We were not able to do an OCT on this child because the OCT that is handheld wasn't there at this time, but otherwise that would have also been done in the same patient. Unexplained vision loss is something that we also do this for. These are the reasons for unexplained vision loss in children. I won't go into this in too much detail. ERG protocols are something that get varied a little bit in children, but more even in adults. We're now starting to do something that's called as a red flash ERG. As soon as we do the red flash ERG, you start to get two responses. So the first response is the B wave response is from the cone system, and the second response is from the rod system. So when you have a two-wave response like this, you can then decide in each of these diseases, and this is done in the scotopic state. This is done dark adapted. This is done when as soon as you've done your dim flash, the next test we do is the red flash ERG to then tell us what to do next. Because when we go according to the protocol that we've started to develop, after patient preparation you dark adapt for 20 minutes, do the darkest of flashes, which is a non-ISEV standard, as you can see, and then we do the standard ISEV flash, and then we go ahead and do the red flash. Now when we do the red flash, we decide whether the cone is abnormal or any of these are normal or abnormal, and based on that we follow up on the other tests that we might have to do. And the other tests that might have to do, the white ones follow the ISEV standards, but the pink ones over here, like the S-cone on-off response, or whether we want to go and demonstrate what Madam demonstrated as the photopic hill or not, those types of things are the types of things that we do before we generate the report. So in conclusion, electrophysiology is an essential tool describing proper retinal phenotype in children with retinal dystrophies. Pediatric ERGs can help with those cases that we discussed, but more than all of that, a small take-home message before I finish. This child was one of the children who came to us with flat ERG response, but she was still playing Coco in school, doing everything else in school. So really, vision and ERG are not equal. As you can see from this certificate, it says that she's 100% disabled. But honestly, if she's playing Coco in school and doing her own work all by herself in her school, then she's really not that disabled as the certificate puts it. Yes, she is by our measure, but not really something that we can take to label a child as being blind. This is another example of a child like that who gave me a pretty picture like this with a cone dystrophy. So technically with a cone dystrophy, she shouldn't be seeing those types of colors, but she knows what to do with those colors, and so really we shouldn't label children by their ERGs, but by their abilities at that point. That's my take-home message as well. Thank you.